Ready. Hi, everybody, and welcome. I am not on a Israel, as you all know. She's unable to be here today. I'm Jen Kolker, Associate Dean for Practice here at the school. It's my honor to be moderating today's session. This is our fireside chat. We don't have a fire. Marianne, I'll bring me a candle, but I was afraid there's a fire last week. So I'm going to introduce Dr. Morita in a moment, and then we are just going to have a conversation. I've set up the questions, and I'm going to ask her, and she'll answer, and then with time at the end, we'll open it up to folks online and folks in the room. So Dr. Julie Morita is Executive Vice President of the Robert Wood Johnson Foundation, where she oversees all programming, policy, research, and communications activities. Before joining the foundation, she helped lead the Chicago Department of Public Health for 2 decades. As commissioner, she led the development and implementation of Healthy Chicago 2.0, a 4-year health improvement plan focused on achieving health equity by addressing the conditions in which people live, learn, work, and play. Dr. Morita served on many advisory boards, including the Biden Transition COVID-19 Advisory Board, advisory committees, and the director of the CDC and the National Academy of Sciences Committee on Community-Based Solutions to Promote Health Equity in the United States. Born and raised in Chicago, Dr. Morita earned her undergraduate degree from the University of Illinois and her medical degree from the University of Illinois at Chicago Medical School. So welcome, Dr. Morita. Welcome back if you have been here before.
Thank you. Pleasure to be here.
So we'll start out with what everybody really wants to know is, can you start by telling us a bit about your career trajectory, including what brought you to your current role with the foundation?
That's great. Thanks so much. It's good to see all of you in the room here today. Many of you I've spoken with earlier today or last evening. I have to just start with by saying that I'm humbled to be asked to be a part of this because I've learned so much about Drexel and the school in the past 24 hours, and I'm just in awe of the vision and mission that you all have and the long-standing commitment that you have to health equity, and really it's truly remarkable. You mentioned, Jen mentioned that I was here in 2017, and I came in and I left, and I didn't learn all about Drexel, but in the past 24 hours I just learned so much about you. Your founding dean, Jonathan Mann, and his vision and his commitment, and how that's transcended throughout the years. So just really honored and humbled to be here to be part of this day with you today. In terms of my background, I'm a pediatrician, and I chose to go into pediatrics because I wanted to focus on prevention. Because when I went to medical school, I could see older folks with their underlying health conditions, ongoing issues, and I looked at children and thought this is to keep them healthy and help them to live long, happy lives. And so really wanted to focus in on prevention. But I was also really motivated from early on in terms of wanting to help people. And I think many of us, I'm sure all of us in this room, kind of have that underlying common theme in our lives that you choose these careers, you choose this path because you really want to help people. And so that was kind of the underlying theme throughout my life and including pediatrics. And then the funny thing is I was talking to some students earlier today about how I kind of stumbled into public health, because when I was in medical school and in practice, I wasn't really thinking about public health. But one of my good friends did an outbreak investigation because he was a CDC assigned me. And he did an outbreak investigation and stayed with me for a month. And I got to see what he was doing. And I thought, wow, that's really cool. I really like to do that. So I joined the CDC's EIS training program, where I was introduced to population health and the ability to impact and prevent disease and really promote positive health for the population. It was just thrilled by this concept. So after I finished that time, I joined the City of Chicago Health Department and spent 20 years there doing the immunization work for the most part. Really had the opportunity to focus on immunizations and infectious diseases. And a lot of the work that we did in Chicago really based on disparities, addressing disparities because we had huge immunization disparities based on race, ethnicity, and geography in Chicago, because it was what I thought of at that time as being a voluntarily segregated city, and learned not so a while back that wasn't really voluntary. But at that time, we were really focused on addressing the disparities. And throughout the course of my career, really continued to address health and equities and disparities as it relates to infectious disease very early. The last 4 years of my time at the health department, really I became a commissioner and had the opportunity to think bigger and broader than just infectious diseases, and had the opportunity to think about addressing social determinants of health, looking at health equity, kind of dipping our toe into our racial equity at that time, and realizing what an impact it could really make. And so when the opportunity arose at the Robert Wood Johnson Foundation, where I could actually focus my full attention and have a lot more resources to think about addressing determinants of health and upstream factors, I really accepted that challenge because it was an enormous transition to go from governmental public health to philanthropy. The sector change was just huge. But really, when I look back at my career, I think about the common thread was this desire to help people, this focus on addressing inequities, and really feeling like I wanted to make a difference. And so to take the lead from local government to philanthropy was huge, but I thought it was worth taking the chance. And so, and 4 years later, I am really glad that I took the chance and glad to have this opportunity.
Thank you. So it's funny, we haven't talked a lot about the pandemic today, but reflecting back on your public health experience and your more recently time at the foundation, what do you see as some of the biggest lessons we've learned from the pandemic about public health? And what have we learned in the last 2 years, and what do you think we can take forward?
Yeah, so I think when I think about the pandemic, there's so many lessons that we learned. But as from a RWJF perspective, I think what I witnessed and what I was thrilled with was that there was a real attention to an acknowledgement of this structural and systemic barriers. That it got away from the fact of blaming individuals for why they were more likely to get sick. So when you looked at who got sick with COVID, who was more likely to be hospitalized, who was more likely to die, it was not so much about individual behaviors and individual choices. It was much more about, well, gee, these folks are living in crowded housing, or gee, these folks don't have paid leave, or gee, these people don't have insurance or can't get to healthcare. So there was an actual acknowledgement of the systemic and structural barriers to people actually being able to have access to health. That was a huge thing, but it really did lift up this concept of structural racism, the barrier. And so while the foundation has been thinking about health equity for a number of years, for a decade or so, we've been talking about health equity. We really didn't start talking about structural racism as a barrier to health until more during the course of the pandemic, George Floyd's murder, just greater clarity on the fact that when we talk about structural barriers to health, we really have to acknowledge structural racism as a primary barrier to health overall. And so I see that as a lesson that has come through the pandemic, that there's this acknowledgement of systemic and structural barriers, and structural racism as being the primary barriers of health and well-being. So that's a lesson that's been learned. What I worry about is that while there's a lot of talk about it, a lot of commitment to it during the pandemic, I kind of feel like interest is waning. And this is not something that we just address for a couple of years and then move on. We really need to stay focused, stay committed, and continue to do this work on an ongoing basis. So I feel like that is one thing that I have about it, that I think that the pandemic taught us this lesson, lifted this lesson, we continue this work. Forward. I was so thrilled to meet with the Wilton Center staff, so Jen and then Sherelle, Ashley came and talked with me at lunchtime and hear about the way you all are working on the enormous gift that you all received at the end of 2020 to really further that work. So this is the kind of work that needs to be sustained, and to see the kind of commitment that you all have here is really true. So I think that's one primary lesson. I think the other thing that I learned through the pandemic is that public health has lost the trust of the public. In the time that I was at the city of Chicago leading the health department, we didn't have that problem. We had established ourselves as a trusted source of information. We were trusted and relied on for a lot of different things. But in the past few years, because of the pandemic, because of the polarization in our nation, you can see how there's just a loss of trust in the public health system itself. And so there's a lot of work that needs to be done to regain that trust. And some of that comes by way of the work at the Ubuntu Center, where you're engaging with communities in really meaningful ways that establish what public health is, help people understand it, but also know that you're committed to working with them for the long haul, not just to come swoop in when there's a public health emergency or a crisis, but you're there really on a basis. So I think that there's that, but I also think they need to do more from a communications perspective, communicating about what public health actually is, thinking beyond just the acute infectious disease emergency, but thinking about how public health relates to education, how public health relates to transportation, education, housing, all these kinds of things. I had month or so ago, I had an opportunity to go to the White House to participate in a conference about lead service line replacements for water infrastructure. And it's because of great work that's happening by others in the foundation, but I got to be the figurehead to participate in the event. But Mitch Landry, the former mayor of New Orleans, he spoke and he said, infrastructure is public health. And I thought, oh my gosh, I almost cried because I thought I'd never heard that kind of, to hear about water infrastructure being equated to health. I thought this is really important. And if more people talked about public health in that way and recognize how much public health is connected to all these different sectors, I think it would help go a long way in terms of earning trust in the public.
So this builds a little bit on the prior question. The theme of our Population Health Spotlight series this year is public health at a crossroads. We didn't want to be saying, the next phase or something's behind us, but where we are now. So when we look ahead at where we are in public health, what do you see as some of our greatest challenges? You mentioned some of those. And where do you think we can make the greatest impact?
So I think it goes into the challenges. The challenges that we talked about really are related to what, the lessons that we learned, the challenges that we are experiencing. And centering equity is really critical. And I see that happening throughout this school. When I talk to every single person that I talk to, students through faculty at all levels, we talk about it. You have incorporated equity into the way that you approach your work, the way that you think about your work, the way that you're doing your research. That's truly remarkable. So I think that is really a challenge that we have, is really sustaining this kind of interest and commitment. Public health departments, over 200 public health departments declared racism as a public health emergency during the pandemic. And so it's really a matter of now. So now that we've made these declarations, what does that mean? I don't know that public health departments actually know what that means, but I think centering equity would be a beginning or start to that, where you're really working with communities, really engaging with communities, building it into your policies, your structures, your programs, but also your organizational structure and how you work as an organization internally. I think people have talked to me about, at RWJF, probably have all this really good from an equity perspective on the internal side. And when I went to the foundation, I was expecting to walk in and have that they have everything down from the contracting to the hiring to all the infrastructure and how we organize ourselves, and we have mastered it. And it wasn't the case. I think it's a lot easier to talk about these things externally and not just look inside and do the hard work inside. I think that is what needs to happen. I can't remember who told me about the governance work that you all are doing, where you're really looking at having faculty, students, staff all working together to make tough decisions that impact you all. And I think that's the beginning of centering equity, really making decisions with those who are most effective as part of the process. That happens internally as well as externally. And I think that's something that really needs to be carried forward. I think communications is a huge challenge, and I think, how do you, even talking about structural racism as it impacts health, is a communication challenge. We just spent over a year doing some research looking at how to communicate about this issue of structural racism as it impacts health in a way that really is as inclusive as possible. And so we did some focus groups, we did some literature reviews, we also did some opinion surveys. And what we found is that there's 31% of the population was understood the connection between structural racism and health. But about 44% was open to it, but really didn't understand it. And then there's 25% that just rejected the connection between structural racism and health. If you think about that, 75%, it would be great if we could get all of us working in the same direction. But what are the messages we need to use to really connect with all 75% so that we're really working together and listen and really making the most and doing the most as we can? So really understanding the science of communication as well as how to communicate about science is going to be so important as we move forward coming out of this pandemic. Because I don't think we did a good job during the pandemic, and I think there's a lot that we can do moving forward. I know, just from my experience sitting on CDC's advisory committee, that they're prioritizing communication because they know that there were some problems that happened during the pandemic, I think the last thing I would say is a big challenge for public health now is really sustained funding. And I think when you look at it, having been in public health for 20 years, I saw the peaks and troughs that always after a public health emergency, there was a surge of funding, and then it would just increase over time, and then there'd be another public emergency. That's what we are experiencing right now. So there's been billions of dollars that have been pushed into governmental public health, but it ends in 5 years, and the clock is ticking. And so what I worry about is that you can't really build a strong public health infrastructure unless there's ongoing sustained funding. And that has, I don't know if we've learned that lesson well enough this round to actually allow this funding to be handled differently and really sustain the benefits.
Much of what we strive to do here, as you've heard about in the last 24 hours, is to translate our research into action and hopefully have some influence on public health policy. Are there particular policy areas you think academic public health can really sort of focus in to help play a role, and how can we partner with public health practice to improve population health outcomes?
Yeah, I think I've just having spent so much time talking to you all, it's so clear that you all are focused so much on human rights. Health is a human right framework, so there must this kind of framework. And so the policies, the work that you're supporting is already oriented in the right direction from my perspective, from the RWJF perspective. I think that we're looking at as you're doing research, as you're thinking about policy, really looking at the connection between structural basis and health, make clear that we have the evidence base to demonstrate that there is this connection between structural basis and health. There is where there is a need for more, but also what are the solutions in actually addressing structural racism to actually improve health overall. So looking at things like reparations, for example, or looking at inclusive democracy, so redistricting, voting rights, those kinds of things, how those things impact health overall. We were talking about paid leave just in the last session, and how those kinds of policies really impact health. And those are the really critical things that need to be looked at and we have on health overall. So I would encourage research in that way, but really being explicit about the focus of structural racism as a barrier to health. The last part of your question was really what can you do to support. So much of what you all do is to put research into practice. And every person that I talk to in the past a couple of days, really you're really applying the research that you're doing to practice. And that's really, really important. I think your role in partnership with state or local public health agencies is really, really important. When I was in Chicago, we had the dean of the public health school is now here. And we established the health department in the Illinois School of Public Health Relationships so that we had this overarching agreement so we could have students work with us, we could have faculty support our work, we also share data with the public health school. The dean and I arranged for this just before we both left, so I'm not sure how it played out, but that was the intent. But I think as we look at the designated workforce of governmental public health, they definitely need support and they need assistance, and you all have a lot of expertise and knowledge and skills that they would benefit from in the long haul. So even when they're trying to hire people using the existing resources, they would benefit from additional support and partnership.
So shifting gears a little bit to your neck of the woods, talk to us a little bit about the role of philanthropy broadly, and then RWJF specifically in advancing public health. How do you work with other sectors to move the needle on public health, and what do you see as the greatest opportunities moving forward? Again, for the foundation specifically, but also sort of the role of philanthropy vis-a-vis other stakeholders and other funding mechanisms.
Yeah, so it's interesting. I referenced the leap that I took from governmental public health to philanthropy before, but that was just enormous. To go from a sector where there are a lot of rules and requirements and policies and procedures and a lot of bureaucracy that we had to follow because that's the way government works, to a place where there really are not a lot of restrictions on us. The requirements that we have are really based on IRS requirements that we spend 5% of our income to do charitable work. And then we have word bylaws that really kind of say that we should go on in perpetuity, these kinds of things that we do. And that we're focused on health. RWJF is focused on health. We have a lot of freedom. But what that freedom comes to us in responsibility in terms of between what it is that we really can and should prioritize. Because we don't have to respond to the acute crisis and the immediate issue. we can kind of look at the long game and see what is it that really needs to be done. So that's why we really doubled down on this structural racism as it impacts health as a primary focus for us. Because we know this is not something that changes overnight. We really have to be in this for a long time. And so we really want to focus on these long-term kinds of things that others might not focus on. When I was in governmental public health, we had a tiny little budget that we could look at social determinants of health, health equity. We had to focus on HIV, STDs, lead prevention. So in philanthropy, we have this ability to look more at the long game. And so it's a privilege. It's also a responsibility. And then we have to stay disciplined, actually stick to that vision and stick to those commitments, because it's so easy to get distracted by other things or these personal interests or the acute crisis that's happening. How do we not get sucked into that so we don't just dribble and travel our funds and our resources away? We really want to be useful. So we have really committed to this focus of addressing structural racism as a barrier to health, to build a culture of health. And the areas that we're really kind of prioritizing right now relate to looking at community conditions. We really want for, as a goal, these generational kind of goals, we like for health conditions to be healthy and equitable. We want for there to be economic inclusion for families' well-being. Really think about the economic systems and how they support families overall, their well-being. And then, even though we talk about determinants of health and kind of we're talking so much about the role of healthcare systems still play a major role in the health and well-being of our nation. And so, really looking at public health and healthcare systems, pushing them to be more equitable and accountable for the public and the community that they're serving. So I think that they are moving toward equity, but are they working toward accountability to the communities that they're actually serving? So those are the areas that we're really trying to prioritize as areas that need to be addressed, will require a long-term kind of commitment and really get at this root cause of structural racism barriers.
We had a really fun meeting with a few students, some of them were here today. But speaking more broadly to those who are joining us now, what advice do you have for people just entering the field of public health? Not just students, but staff and faculty as well. And what excites you about the next generation?
Yeah, so I think when I think about what advice I would have, I would say be patient in public health, because change happens, but it doesn't necessarily happen quickly. And so I think about wins that we've had, whether it's related to tobacco, or whether it's related to elimination of some vaccine preventable diseases. These things take time, and they don't go away right away. So you have to stay persistent. You have to continue to work through challenges and stay focused on what is it you're trying to accomplish. I can't remember who I was talking to today. It's talking to somebody people today, but somebody was saying that when you have to know what is the goal. Keep the goal in mind, because you're always going to have setbacks and things that get in your way. But if you keep that goal in mind, that'll keep you motivated, help you get up every day and fight the battle that you fight every day. But recognizing that you do need to be patient, because things aren't changing, will happen over time. And then I think building on that is be vigilant and be persistent. Because when I think about things like tobacco, even though there are wins, we have lower youth tobacco rates we've had in the past. There's vaping products that are out there fully marketed toward young people. And so while we can celebrate the success that we've had, we also have to acknowledge that there's new threats that are emerging all the time in the form of vaping or in the form of emerging infectious diseases that are happening. So you have to be vigilant and you have to be persistent. And I think the last time there's one other thing, but I feel like those are the key things that I would really focus in on. And what gives me hope about the future, I have a 21-year-old and a 26-year-old, and in them I see so much of the future, because they are passionate and they are committed to equity, and they recognize structural racism and the barrier it is to health and to well-being, and just the poison it is to our society. And I feel that when I talk to the young people at work, they really push us older folk at the foundation. They really motivate us and they inspire us. And I feel like the this was happening even before the pandemic, where I feel like young people were really kind of charged and aware of what's wrong with our society and willing to attack it and challenge it, but also willing to think creatively about who needs to be a part of the conversation. So that's something I haven't really mentioned, but I really like that is a core element of this future that we envision is really that we don't look at the old traditional ways of doing things. We stick with those things. We really open ourselves to basically new ideas, new sources of knowledge, recognize the expertise and experiences of people from all over, and really incorporate that into the solution that we take overall. So I see a lot of hope, and I see a lot of promise for the future because of the youth that I see on a regular basis. And then also I see hope. I have a lot of hope and promise because I see all that you at Drexel are doing. I really think you are trailblazers in the space of health as a human right and the social justice fight in Asians. True.
I said to Dr. Morita earlier, it's always nice when we have people come in because it gives us a chance to see who we are reflected in someone's images of us. So it's always energizing. We have questions online or people putting into the chat. Let's start with, we'll go back and forth. Are there questions, some questions first in the room? Yes.
You talked about working in governmental and now you're outside of governmental. How would you, envision more cross-sector partnerships, kind of like the one that you were talking about with the previous dean and the school in Chicago? I think that's another thing, with the intersectionality and interdisciplinary that you were talking about that we could do more in public health, especially with resources and with funding. So how would you see that envisioned if somebody, wanted to do more of that or wanted to, make that their charge?
I think that was actually the last piece of advice I was going to give related to what to do moving forward with public health is really to think beyond just traditional health definition. Really look for those opportunities across disciplines. Because I think that is how we are going to be successful. In Chicago, we had a health in all policies. So I was commissioner when Mayor Emanuel was mayor, or Ron Emanuel was mayor, and he actually agreed to have city council require all the city agencies to work with the city health department. All it was they had to work with us. It was not specific. So we had a variable uptake, but we had some really good partnerships with the Department of Transportation. They were great partners with us. They really wanted to work with us. They would reach out to us and say, this is we think there's a health implication here. How do we think through this policy or complete streets or something like that? They would always reach out to us. Other agencies didn't necessarily do that, but it was really a valuable experience for us to do that. And then also we would engage. It's an interesting thing to do when you have city agencies or governmental agencies trying to work together because everybody has their little. You all think about siloing within the university, I'm sure. Well, in government it is equally as bad, and I think we all have our little domains. But the one way that we were actually able to get their attention was leveraging our data, because we had public health data and we had people who analyze data. And so we would say, if you have streets and sanitation, if you have some data, we could potentially analyze that data or work with you or partner with you, or we have some data we can share with you that might help further your work. Suddenly they became a little more interested in working with us. So it is really kind of being open. We always approach it in a way of, we're not coming here to tell you what you need to do because that would not have worked. But we're here to stand beside you and to add value to whatever proposals that you have, and maybe give you some perspective of how you might tweak your policy or your proposal, because maybe there is a different way to think about it. We never went in saying we're going to tell you what work, but it was really much more of how can we work together. We have some resources that you might like. We like to benefit from your resources. Can we partner together? But this cross-sector type of thing is just critical. So as you're thinking about ways to work in the future, I would encourage you to think about that.
Lauren, you want to do one of our online?
In terms of your comment a little ways back about public health has lost the trust of the public, how much do you think is due to the influence of politics, and are there ways to minimize that effect?
Well, yeah, it's not politics. No, I think there are politics that are involved with it for sure. I think one of the ways to work through this though is really engaging with the public. I think so often with governmental public health, people didn't pay attention. Governmental public health is just under the radar until there's a crisis. And then public health becomes recognized as no. But that's not an effective way to really earn trust or establish relationship. Well, how do you earn trust unless you really establish a relationship? I think when I look back at the pandemic, it's a great example. When we saw the early rates of disease, and we saw the disproportionate impact it was having on our communities of color, our low-income communities, our frontline workers, there was a recognition of the inequity. And so early on in the pandemic, there was a lot of attention being paid to health equity. In ways that I was shocked. For people who've been working on health equity for a while, it was just hard to believe the federal government was talking about health equity. Wow, that's really remarkable. They have a health equity task force. This is truly remarkable. They also pumped lots and lots of money into state and federal governments, state and local governments to engage with the community and give money to communities, actually work with the community to talk about vaccines, to talk about testing, to help do contact tracing, to help people navigate the systems to get the vaccines, to get the testing. Those resources came out because when you look at the early primary series vaccination series disparities, they narrowed. And a lot of that had to do with the resources that were actually pumped into community. To have the community be the voice of the prevention measures, of the response activities. And that's a way that you really earn trust, is by investing in community, investing in relationship, and an ongoing basis. So it's not just in the middle of a crisis, because you're not going to earn trust or gain trust in the middle of a crisis. You really have to have an ongoing relationship on a regular basis.
Questions in the room?
I have one. How can data be used to sort of elevate the area of public health as it partners with other agencies? How you mentioned that you leveraged the data that you had with the transportation department, and I'm very curious as to how we could then leverage data to become better partners and then elevate what we're really concerned about with our community members.
Yeah, so earlier today we were just talking about county health roadmaps and rankings. That's a tool that the foundation is supported by way of University of Wisconsin. And it maps out by county different health outcomes, different health metrics. It also has a what works type of an approach to how you can actually use the data and improve community conditions overall. We were just talking about how some of the metrics need to be expanded and we need to do more for the metrics to actually have relevance to other sectors, because they're very health specific, health oriented. So we are working to build out those metrics. So I think there's more work that needs to be done to identify the appropriate metrics to use to make them relevant to other sectors. I think we in health often think about the health outcomes, but not thinking about determinants of health, structural racism as a factor, and how do you measure those kinds of predictors of health overall. So making those kinds of metrics, determining what those metrics are and including them is really important. We have used that county health rankings and roadmaps to actually develop congressional district maps. So they're maps that look at the health outcomes as well to get a congressional district. And those actually are being used right now we just launched them earlier I think the end of last year, beginning of this year, and they're actually being used by congressional staffers to inform policies. So we've heard feedback based on that. So I feel like those kinds of tools it's a matter of asking them what it is that they It goes back to understand what are the needs, what are the needs. So we heard from congressional staffers and advocacy groups, they wanted to have the county health rankings and programs are great, but they're at the county level that doesn't really help us. What they want to know is the congressional level. What is how that's the kind of information that is most valuable. And so really we took the time to try to figure out what was most valuable and then try to come up with a tool. So I feel like that's the kind of conversation that the county could have as well, as that as you have your data, what would be valuable to what would be valuable to housing, what would be valuable to other sectors, so that provide as
Yeah, you spoke into this in a little bit, but do you have any proven tips on how agencies and counties can build back trust with the public?
It's time and relationship. I mean, and also I think the other thing is time and relationship is one thing, but I think it's communication. What and how things are communicated need to change. Because I think what happened is with public health messaging, when I look back what happened with COVID, and I would be if I had been in governmental public health, I would have done the same thing. We came out with what the guidance was. This is what you should do. These are the things that you should do. We didn't do it. We didn't acknowledge that that's what we knew at that time, and that the science was evolving, and that those the guidance and the recommendations might actually change, because it was an emerging disease. In our understanding of mass, our understanding of social distancing, our understanding of all the different things that we were trying to implement, air ventilation, our understanding deepened and got better and was more precise as time went on. And so some of the recommendations changed over time. But that's not the way the public heard it. The public heard, this is what you need to do, and this is what we know this is right. And then when there was a shift, then, well, what are you saying now? And it's the way that it was communicated. So I think it's really is being able to communicate what we know, when we know it, and that it might actually change based on more knowledge, more science, more information. I think that's one way to do it. And I think also just this concept of establishing relationships on an ongoing basis is really, really important. The example that I think of too was in Chicago. We had done some community health improvement planning with community groups throughout the city of Chicago. It was to help us develop our plan. We went out and talked to communities, we established relationships with them. And then to implement the plan, we continued to engage with the community as part of implementation of the plan. So they were part of it, so we had relationships. And so when the pandemic actually broke out, the outbreak occurred, the mayor's office worked with, this is after I was gone, I can't take credit for this at all, but the mayor and the health department worked together to convene these groups that we already had relationships with and asked them to be part of the response. They became the racial equity rapid response, and they were mobilized to go into communities. But this because they already had a relationship with the city, the government, and so they knew that it wasn't that they didn't go out and do it right away and try to find a new group to work with. They already had this relationship and then built on that. And so I think that's how you do it: is you have relationship over time, and then you communicate frequently and consistently, and then also represent it accurately in terms of how much you know of it and what you can give it credit.
Other questions here? Yes,
I have a question now about the availability piece. I think that it's, pretty, I don't want to say easy, but easier for researchers to think of interventions that directly involve behavior of people, individuals. And I know a lot of the on What Works, on the What Works website, a lot of it is around people's too, how can we change particular behaviors. In general, I think that researchers are sort of trained to think that way. But when you think about trying to change systems, which is very important for what you're talking about in priorities around structural racism, I've had this fear that, only progressively minded places will get funded because they're sort of thinking already about how to change the systems. And you see that happening in a lot of states that have more progressive policies and democratic leadership, a more willingness to, one, acknowledge that structural racism is a thing, and then a willingness to do something about it. And, thinking 20 years down the road, if these other states don't acknowledge it and don't create systems to change it, we may actually widen, these geographic disparities over time. So I'm curious to hear, is there plans from a targeting approach? What can we do to ensure that there's that equity and sort of funding across differing states with differing political mindsets and willingness to make a change in those areas?
Yeah, I think that's a great point. I think it is. We're really trying to get to the system level change versus the individual behavior. It's good mindset. When you think about it, the people who are focused on more the individual behavior are really very much of the bootstrap, the individualism kind of mindset that all you have to do is work hard and you can overcome anything, or you just to change that particular behavior and your health will be good. It's really not just that. And so I think we are looking at the system levels. And thank you for acknowledging and lifting that up. I think the challenge that you talk about is really this polarization that we have within the country. And your concern is that we will only fund those places that are really just focused on structural racism, the barrier to health, and geographically. We don't really fund geographically. So we're looking more at organizations or entities that are doing work that is in alignment with our priorities or our goals. And our policy group in particular with this, the focus has a strategy of looking at in terms of engaging the right of center groups. Because we recognize that's just what we require. Because that will only get us so far. But there is this middle ground, like it kind of goes to the structural racism messaging research, which there's this 44% in the middle who are open to this. We don't want to lose them at all. So we have to think about that deliberately. So the work that we do has to be more across the nation, trying to reach as many places as we can without trying to be focused on particular geographies based on the politics in the area. So I would say the issues that we focus on are not are clearly progressive. I mean, we are acknowledging that that's where we are right now. But I also feel like we have to recognize that we have, because of our reputation, because of our brand, we have an ability to cross the aisle and to actually get people to recognize focus on evidence-based work that we've done in the past, that we have done in the past, and continue to do. That will test the credibility of our audiences as well, and our goal is for
I would just ask a quick follow-up to Jan's, which is that middle ground was that 40% or 30% were open to it. How would you sort of get to those people or fund organizations who are sort of just maybe starting to think about it, but not nearly as, I think it's a little bit what you were getting at, articulate and clear about what they need to do next. Like because I think in public health, whether it's structural racism or anything else, there's that middle ground, right, of everything. There's everybody that's going out to get vaccinated. That's great. There's people who never will, and it's all the people in the middle. How do we get the people in the middle?
It's interesting. So from a messaging perspective, we've done this research that the message testing that we actually did with recognizing there's a 75% of the 44% in the middle. It's really focused on leading with values. That so often in public health, I'm CDC trained, and so whenever we would start off with a presentation, these are the data, disease burden, start with disease burden. But that actually doesn't really resonate. And so really leading with the value, like what is the shared value that we all have? Because there is that shared value process percentage really that we all want everyone in America a fair and just opportunity for health. That's a shared value. We all want that. And so then you can get into what is the vision for what it is we want to, that we envision, and then what is the problem statement. So you can get into it after that. And then ending with what a collective action is, because everybody wants to be motivated to do something. So from a messaging perspective, that's what we're leading with values, then talking about the vision that needs to be, and the problem statement, because we have to acknowledge what the problem is, and then ending with what the action is. So that's at a real high level in terms of what we're pushing this. But that's a way to be more inclusive of this middle ground, which is important ground that we want to have alongside.
Thank you.
There's another one online. You've had a long and amazing career in public health. Any advice for not burning out and maintaining focus, particularly during a public health crisis like the pandemic?
Yeah, I don't know that I could have been. I think I would have been burned out through the pandemic. I was not in governmental public health during the pandemic. In the beginning of the pandemic, when I was sitting at RWJF, I was feeling very guilty. Like I should be part of this response, and I really wanted to get my role. And so I helped out Illinois State. I helped out the city in some ways, and then I had the chance to sit on the Biden task force. So that was really exciting, and I felt like I was part of it. But as the pandemic dragged on and on and on, I felt the public health officials, the public health workers throughout the nation did unbelievable work throughout the pandemic, and I don't know how any of them aren't burned out and don't feel harmed by the whole experience, because on top of all the work that they actually did, then to be criticized and to be maligned and threatened, it's just unbelievable. It's unfathomable. So I don't know how anybody can sustain that without having been, having been burned out. I don't know how that's possible. I had the good fortune of having troughs of activity where I could recover. I also had a very strong social support system. So I'm a mom of 2 children and saw several public health emergencies during the time that I had a career, but I have a husband who's very supportive. My parents live 3 blocks away from me. I had a strong safety net that helped support me throughout that whole process. And I think that's really important to think about is you're heading into your career, what kinds of making sure you have those kinds of social supports, because it's not easy work. No matter what you do, there's demands and there's peaks and troughs, and having a strong social support is really good.
Any other questions?
One more.
One more, okay, one more line and then just,
This one is, New Jersey has a lot of social and public health initiatives, the latest being healthcare for children. Given this, does RWJ ever find itself competing with the New Jersey Department of Health? Is there a beneficial partnership with the state of New Jersey in particular?
Yeah, so New Jersey has always been the home of Robert Wood Johnson Foundation. So our founder was Robert Wood Johnson's second, and he is connected to Johnson & Johnson. But there's a strong presence. We've always been in New Jersey, and we have a strong connection and partnership with the public health department. So I would never say that we're in competition. In fact, it's a very good relationship. In fact, Rich Besser, our president, supported without a governor task force during COVID. We got to sit on the task force for the public health department during COVID as well. And so we have a strong working relationship. So it's not at all. There's so much public health work to be done. There's no competition. It's more partnership.
just that.
Yeah, I wonder if you could share some of your thoughts on the role of philanthropy in terms of funding research and how that might compare or contrast with something like the NIH, which also does, has long-term visions and goals. But
that's great. Yeah. So I can't speak for philanthropy in general. What I can speak for is RWJF, and RWJF has had a long history of supporting research and evaluation of learning. And in fact, we've done some brand work recently, and we're known for being evidence-based, kind of slow-moving and evidence-based. And I wouldn't disagree with that, but we are very evidence-based, and so we have funded a lot of research in the past. I think where we're heading with our research is really looking at pushing the health, science, and knowledge system as a whole, including academy, to be more equity-oriented. And to think about sources of information differently. So what is evidence? How do you think about evidence? How do you think about data? Making sure the data reflect the communities that really need them to reflect. And we saw that play out when you look at the COVID and how little information is available by their race, by ethnicity, by even geography. It's just so incredibly limited. So really pushing for more work to be done in that space. So our budget pales in comparison to what NIH has, and so we do fund research, but it will be more focused on our priorities related to structural barriers to health and pushing the system.
Question. Any last comments from you?
Yeah, it's funny, when I was preparing for this, I was kind of thinking, I'm expected to share my knowledge and my experience with all of you. And what I came away with in this past day is I've taken so much more from you than I've given to you. I've benefited so much more from just the time that I spent about your work and the vision of the school and all the great work that you're doing. I want to thank you all for taking the time to meet with me throughout last night through today. It's just been an incredible day, and I look forward to engaging with you and working with you.
Terrific. Thank you so much. Popcorn reception out in the lobby. I think Dr. Morita will be here for a little while longer until she has to have a train. So thank you all for joining us. Thanks everybody online as well. Jen, thank you.